I'll let everyone.
Good morning, everybody. I'm just going to give it a minute for people to shuffle in the virtual door, then we'll get started. All right, let's get started. So welcome, everybody. I'd like to acknowledge that the Women's Health Research Institute are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh Nations, and is a provincial research institute committed to improving the health outcomes of women, including those across the 2SLGBTQIA+ spectrum. We recognize our responsibility in the collective efforts towards establishing culturally safe healthcare systems and services that address the health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And as we gather in spaces together, we encourage you to reflect on your own positionality on these lands and your personal commitments to reconciliation. And with that, I'm very pleased to be able to introduce our round speakers for today. Dr. Charissa Patricelli is the Research Director for the Perinatal Addictions at BC Women's, a physician on the FIR, which stands for Families in Recovery Inpatient Unit at BC Women's Hospital and Health Centre, and a member of the WHRI. She is the educational co-lead for the UBC Health Clinic in the Department of Family Practice and a clinician assistant professor at UBC. And Taylor Ricci is, am I saying that correctly?
Yes.
Hopefully. Okay, thanks, Taylor. Recently graduated with a Master's of Science from the Women's and Children's Health Science program at UBC. She has worked as a research assistant for Dr. Patricelli and the FIR unit since 2021. And she's currently a clinical research coordinator at the Clinical Research Support Unit at BC Children's Hospital Research Institute. So welcome, Charissa and Taylor.
Thank you.
Thank you so much, Catherine. And Taylor's going to start us off in the presentation. So thanks everyone for being here. We're really excited and honored to be able to share some of the work that we have done on FIR and with this research study.
Thank you. So to just reiterate Catherine's land acknowledgement, we want to acknowledge as well that UBC, BC Women's Hospital Healthcare Centre, and the FIR unit operate on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. And this acknowledgement, gratitude, and respect extends to all the First Nation communities on whose traditional territories the Research Institute builds. So today we will be discussing our recent publication entitled Neonatal Opioid Withdrawal Syndrome, Monitoring, or NOWS Monitoring, Not Requiring NICU Admissions, Examining Rooming In as a Standard of Care. So this paper was written to demonstrate that the current clinical practices at the FIR unit at BC Women's Hospital for infants diagnosed with NOWS are safe and effective, and that NICU admissions and/or continual cardiorespiratory monitoring is not necessary for infants requiring morphine to manage the symptoms of NOWS. The objectives of our talk will be to gain an understanding of how NOWS is clinically approached at BC Women's Hospital, to understand some of the unique challenges in research with multiple stakeholders, and to see the frontline clinical research and international impact from BC Women's Hospital and BC Children's Hospital in the treatment of substance-impacted infants. And I will let Dr. Patricelli just discuss a bit about the difference between NAS and NOWS.
Good morning. Yes. So just to clarify around the NAS and the NOWS definition, certainly in the literature, the term NAS or neonatal abstinence syndrome was the original term used to describe the constellation of findings that occur as a result of neonatal withdrawal from exposure to substances in utero. And initially, this was primarily opiates. But NAS really describes a whole constellation of symptoms that can be observed with withdrawal from opiates, nicotine, SSRIs, and benzodiazepines. In contrast to our more current definition of neonatal opiate withdrawal, or NOWS, which is specifically symptoms that are related to exposure to opiates in utero. So traditionally, treatment for NAS, which was lumped in with NOWS, was with morphine treatment and monitoring of the baby to see if they required that based on their physiologic symptoms of the vital signs, the GI system, and neurologic symptoms. Certainly, we use tools to monitor for the overarching neonatal abstinence syndrome when there is exposure to substances other than opiates. But we want to be really careful that we are not treating the neonatal abstinence syndrome that does not include a baby exposed to opiates with morphine. So that's where it's important just to differentiate. Certainly, polysubstance is the bigger overarching issue. And has become more complicated in the recent years, but just to differentiate the definitions of the two words. Thanks, Taylor.
So what we've been seeing in hospital and what we know is that the opioid crisis, which has been about a decade in the making, has a significant effect on both pregnant people and infants. So between 2010 and 2020, there were almost 17,000 neonatal abstinence syndrome hospitalizations across Canada, excluding Quebec. And what we know is that there's been about a 73% increase in hospitalizations for infants with NAS from 2010 to 2020. However, it's not known how many of these infants went to the NICU for cardiorespiratory monitoring for MOS alone versus those who had complex medical needs that actually required a higher acuity of care. So a review of 103 Canadian hospitals found that 45% of infants are directly admitted to the NICU solely for NOWS management, and 89% of infants are directly admitted if pharmacological treatment is required, even in the absence of additional diagnoses. So based on the trends and what's observed in clinical practice, these rates are expected to have been increased by now in 2025. So admission to the NICU is not only increases costs to the healthcare system, but also disrupts the parental-infant dyad, as not all NICUs are able to support rooming in and may discourage the maternal-infant togetherness, especially in marginalized groups already experiencing distrust with the healthcare system. And I will let Charissa speak a little bit about what is happening here at BC Women's and on FIR.
Thanks, Taylor. Just a little bit of background on FIR, and many of you will be familiar with the Families in Recovery. This unit has been operating at BC Women's for over 20 years now, and people who work here are really passionate about the care that they are providing and the service that they want to give to the families that are impacted by substances. The unit looks after patients during the prenatal period as well as the postpartum period. They don't deliver their babies on the unit. They go down to labor and delivery for that. But it really is based on a harm reduction model People do not have to be entirely abstinent to attend because we feel it's really important that the fact that they are pregnant and receiving prenatal care and deliver in a hospital is very important. And so it serves all women regardless of what their stage of recovery is. A lot of work has been done in terms of like education and to continue the momentum in being trauma informed and trauma responsive, and really embedding Indigenous cultural safety and the inclusion of Indigenous peoples and professionals in the care that we're providing. I think the biggest thing that many people are very passionate about is the model of mother-baby or birth-parent baby togetherness and promotion of the rooming in model. And that has been, that was started over 20 years ago by some of the pioneers in nursing as well as in medicine in terms of establishing that. And we're really fortunate that we were able to recruit those people to help us in reviewing our paper as well in the recent data that we were able to publish.
Yeah, thanks, Charissa. Sorry, I just couldn't find my unmute button. So yes, to expand a bit on what Charissa touched on, the rooming in model is the practice of care for the birth parent and infant to stay together in the same room immediately from birth. The rooming in model emphasizes parental involvement in infant care, maximizes non-pharmacological interventions such as swaddling, skin to skin, decreased sensory stimuli, and increased breast/expressed milk feeding to manage withdrawal. And most importantly, the promotion of the birth parent as the expert in the infant's care. The team at FIR has been pivotal at publishing on this clinical model of rooming in for infants with NOWS. In 2007, led by Dr. Ron Abrams, it was shown that rooming in is associated with a significant decrease in the need for pharmacological treatment of neonatal abstinence syndrome and shorter newborn length of stay in hospital than standard nursery care amongst opioid-exposed newborns. Rooming in also increased the likelihood of newborns being discharged into the custody of their mothers. In 2010, the FIR team also published further research to support the practice of rooming in a comparative review of substance-exposed infants who experienced rooming in versus the standard of care. Rooming in was associated with a decrease in NICU admissions and shorter NICU length of stay. Rooming in also increased the likelihood of breastfeeding during hospital stay and increased odds of the baby being discharged home with the birth parent. A more recent evidence from Ontario has found that when infants are able to room in, the average length of stay in hospital decreased from 24 days in traditional NICU to 5 days. And additional evidence suggests that rooming in may reduce child apprehension and motivates birth parents' engagement with substance use treatment. In summary, evidence from FIR and beyond support rooming in as a standard of care for women who have used substances during their pregnancy and their infants. In the literature, rooming in is associated with a range of medical and psychosocial benefits, and these benefits include a higher level of maternal satisfaction with birthing and hospital experience, more hands-on involvement with infant care, increased bonding and attachment, and improved symptoms of neonatal abstinence syndrome. And systematic reviews have found that rooming in is consistently connected with higher rates of breastfeeding, lower rates of pharmacological treatment, reduced treatment length, and shorter hospital stays. Additional benefits include faster response to infant hunger cues or discomfort cues, increased privacy for birthing parents to provide skin-to-skin contact and breastfeed, and more opportunities for partners and family members to participate in day-to-day care, and increased family unity where child welfare agencies are involved. So despite all of this evidence in support of the benefit of rooming in as a model of care, there still existed a gap in the literature that there was no evidence to provide no clinical evidence providing that rooming in was safe for infants with NAS or NOWS being treated with morphine. And we were finally able to addressed that knowledge gap with our 2024 publication, Neonatal Opioid Withdrawal Syndrome Monitoring Not Requiring NICU Admissions as a Standard in Care. And when I say recent publication, this has been a labor of love for many groups and individuals, and I'm very pleased to be sharing our results with you today. So our paper is a 5-year retrospective chart review from infants admitted to the FIR unit between 2014 and 2018. We looked at all infants who were born or admitted to BC Women's Hospital, diagnosed with NOWS, and given morphine to manage withdrawal symptoms. So this isn't the total number of infants with NAS or NOWS that were seen on FIR from 2014 to 2018, but rather all those with NOWS who were given morphine. We performed a chart extraction to independent reviewers, and then later, once anomalies and outliers and missing information was addressed, a third reviewer re-reviewed for accuracy of the information. Data that we gathered included morphine treatment, associated respiratory status of the infants on morphine, any reason for NICU admission or transfer from FIR, and subsequent length of stay in the NICU. Two-way ANOVAs were performed to investigate the effect of NICU and FIR admission and gestational age on the outcome variables, such as length of morphine treatment, starting dose, highest dose, and lowest respiratory rate on morphine. So some of our results found, so any maternal information was gathered from the infant's chart. So there is a little bit of limitation in what we were able to understand about the birthing parents of these infants. But what we do know is that maternal age ranged from 20 to 44 years old. 80% of mothers received some prenatal care at some point throughout their pregnancy. Mothers experienced other comorbidities, with 46% presenting with mental health diagnoses, 37% presenting as Hep C positive, and 23% with STIs. And that housing insecurity was significant for birth parents. 28% of birth parents reported living in SROs or shelters, with 28% SROs and shelters, and 24% with stable housing. 17 were experiencing homelessness, and for 34%, data was not available. So 96% of these birthing parents delivered at BC Women's Hospital. 4% have unplanned pregnancies outside of the hospital, unplanned deliveries outside of the hospital. Interestingly, 42% of parents chose to breast or chest feed or give expressed milk, and 33% of that 42 chose to breast and chest feed while they were on opioid agonist therapy. We know that approximately 70 out of the 82 parents reported non-prescribed substance use during pregnancy, and 82% were on opioid agonist therapy, primarily methadone. And what we know about these 82 infants between 35 and 42 weeks gestation treated with morphine is that positive pressure ventilation was performed on 12% of the infants at birth, and the 5-minute APGAR score was greater than 7 in 64 of these infants. We know that of those 84 infants, we know that the mean length of their morphine treatment was 15.5 days, and the morphine treatment ranged from 5.4 days to 46.4 days in those infants. 35% of infants had their entire stay on FIR and never went to NICU, and 65% of those infants were admitted or transferred to the NICU at some point during their stay. And we know that there was no effect of gestational age on the rate of NICU admission or the mean length of NICU length of stay. So why did those infants end up going to the NICU? The primary reason for infants going to the NICU was for respiratory distress, which it can be a concern for infants when they're on morphine. That's kind of why infants are sent to the NICU. But It's important to note that respiratory distress is really a catch-all code that's used to describe any type of respiratory diagnosis that might send an infant to NICU. So this could be that they needed oxygen for a completely separate diagnosis, separate to their morphine. And I think it's important to know that of the 31 infants with respiratory related admissions, none of them were for apnea associated with morphine use. Actually, of the 9 infants who were transferred from FIR to the NICU, 8 of them were experiencing tachypnea. Other reasons why infants may have gone to the NICU include poor feeding, the need for NG tubes, ruling out sepsis, or complications at birth. When infants were on FIR, they had their vitals assessed every 4 hours while on morphine and experiencing the withdrawal period. And what we found is that nurses on the unit were very comfortable with fluctuations within these infants. Nurses tolerated transient decreases in respiratory rates to that of between 30 and 40 breaths per minute. If upon additional assessments, these babies were looking overall healthy, and this decrease in respiratory rate was seen to be transient. Nurses provided multiple alternative methods before calling a physician, which includes non-pharmacological support like cuddling, assessing oxygen saturations, and increasing frequency. So all of these actions were taken when lower respiratory rates were observed. And these babies stabilized after those events of lower respiratory rates. And we observed that the nurses and healthcare providers on the FIR unit were able to successfully identify infants who required a higher level of care from this Q4 monitoring alone. So that is to say, there's no evidence of respiratory depression or any respiratory event that didn't receive appropriate follow-up care, either in the moment by the nurse or through NICU admission. 97% of the infants treated with morphine had no evidence of respiratory depression, so that's decrease in respiratory rate, with an associated clinically relevant decrease in oxygen saturations while they were on morphine. 2 infants had isolated instances of reduced respiratory rates and associated oxygen desaturations. Both of these infants were experiencing comorbidities in addition to their morphine treatment for NOWS, and they were cared for appropriately in the NICU. So to give a summary of what we found and the important learnings of this paper is that infants who are greater than 35 weeks gestational age on morphine for NOWS management in the NICU didn't experience low respiratory rates with clinically significant oxygen desaturations, which would suggest that morphine management of NOWS on FIR is done successfully at the Q4 vital assessments and doesn't really necessarily require the continuous cardiorespiratory monitoring of the NICU. And that infants who are greater than 35 weeks gestational age requiring morphine for treatment of NOWS without comorbidities can be safely managed without this continuous respiratory monitoring outside of the NICU setting. And this promotes the rooming in model of care and mitigates financial burden on the healthcare system. So that is sort of a bit of an overview of the results of our paper, and I will let Charissa speak a little bit about sort of what I've talked about as well as the journey of this research.
Thanks, Taylor. That was a great overview. I think this has been a project that we have been working on for probably 5 years, but it is really important because the model of care of moms and babies staying together, even when the infant requires morphine and not separating the dyad, we know that there's value in it. And a lot of that was presented at the beginning. However, internationally, the standard of care is that the infant would go to the NICU for continuous cardiac monitoring while they're being treated with the morphine. And so because FIR has been doing this for 20 years, we felt it was important to look at what are all the baby's vital signs. And this project was really, really great for that, because the babies who went to NICU for another reason, we could look at all of their 24/7 vital signs and their monitoring for all of the heart rates, and see where there was desaturations or which babies experienced that. And so that was very wonderful to be able to look at all of that data. It took a long time. So we had a chart pool, and then COVID happened and the whole project was suspended for a period of time. Then when we reviewed the data, there were some outliers, so we had to re-pull all the charts. You imagine that was like back on the giant paper charts, and some of those charts were, most of them were very big. And so I'm very grateful to Taylor and a lot of the people who worked on the project to get this finished. When we submitted our manuscript, one reviewer said, well, this is already being done, so why this doesn't need to be published? And we're like, but there's actually nothing published about the babies showing the vital signs, or that it's safe from a respiratory perspective, that they can be safely monitored without going to NICU. So it did take some repeated submissions to get it accepted. And, you know, the fact that you can publish something that's really important to your clinical practice is really inspiring, because we have had many people reach out to ask us to talk about this work. Nicole, our patient care coordinator on the unit, and myself were able to travel to Australia prior to the publication of this, just to talk about the rooming in model. We will be presenting at the Canadian Society of Addiction Medicine. You know, in addition, we've got a number of other organizations, community partners, and Perinatal Services BC, some of the leaders from that institution were also involved in helping us review the data for this publication, because it spanned over so many years. And in terms of provincial guidelines for rooming in and for the care of babies, this is an important one, because people have something to hang their hat on, that they're practicing within a safe model, and using some tools to do that. And we've been able to use this in the development of the Eat, Sleep, Console, and practices around the non-pharmacologic interventions, and honoring the birth parent as the expert in infant's care. So that whole model has been able to grow substantially. And we're really grateful for all of the collaborations on this work, spanning right to some of the people who worked on FIR in the early days, like Rob Everett and Ron Abrahams, and others who were involved more recently. So thank you, Taylor, for reviewing all of that data.
Thank you for speaking about the importance of the work. So in conclusion of our talk, to reiterate our learning objectives, I hope that you have seen us demonstrate that the clinical approach to NOWS at BC Women's Hospital, focused on rooming in the parental infant diet and reduced NICU admissions, has been proven to be safe and effective for the management of infants on morphine. I think Charissa can attest to the fact that research poses many unique obstacles with and beyond our control, but navigating those challenges are very worthwhile when you're publishing important clinical data like this. And research that's done at FIR has a very important local, national, and international influence on the treatment of substance-exposed infants. So I'd like to say thank you to Charissa, as well as the frontline clinical team on the FIR unit and all of the families who are involved in this research study, as well as for the opportunity to present here today and for you all in the audience. So thank you.
Thank you, Charissa and Taylor. This has been a great presentation. I'd love to be able to open it up to questions from the audience. So if anybody has any questions, please, oh great, Dr. Osievich, please go ahead.
I thank you. It was a really nice presentation. Congratulations. I think it's very important, and I think that it's very important to have the busy women on top of that. This study was done, I had the impression that was done in the kind of in the old setting. So any comments about something in between FIR and the real NICU, like the mother baby unit? Any experience about that? Because we had that possibility as well.
Yeah, that's a great question. I think that the charts that were pulled, they definitely were the early part of the fentanyl crisis, 2014 to 2018. And we had no funding to do this. We would love to be able to do a more recent look at the data. To be honest, I think that the model in terms of the rooming in is very similar to what it was previously in terms of the setup of the unit. The unit moved, but almost all of our patients are admitted to FIR. The mother baby unit has a very select group from FIR that might be admitted there. We've tried to maintain that same model where we can. However, there's some barriers just around like the ability to engage with the families when they're quite far physically from the FIR unit and wanting to stay with their baby all the time. And that's fantastic, but a lot of the model in terms of the wraparound services that are on FIR is somewhat unique.
That's great. And I have a question here asking about the dosage regimen for the infants and was it reduced over time? And maybe that's an individual case-by-case basis, but wondering if you could comment on that.
Yeah, certainly the dose regimen is a starting dose of 0.04 milligrams per kilogram, and then is titrated up. It's given Q4. We've been able to create an algorithm currently that's published online through Perinatal Services BC and BC Women's, and it has the pathway for the morphine treatment. In the study, that was the starting base for the infant dosing, and then it would be titrated based on the infant's needs and then weaned off once they were not experiencing any significant symptoms of opiate withdrawal.
That's great. Thank you. We also have a question asking a little bit about your knowledge translation. So in addition to your conference presentations, could you speak to how else you are sharing the findings and who you were targeting in terms of audiences? So clinicians, providers, decision makers, etc.
Yeah, thanks for the question. I think that's always the challenge in terms of accessing the right populations and people who are providing care to share the information. I think the drug crisis is changing continuously, and the polysubstance is such a challenge. And so we continue to need to support the people who are working frontline with these families. There's always been fear and stigma in this work and in the populations that we work with, and we're really hoping that we can share the presentations for this and for some of the other research work that we're doing on FIR at nursing conferences, at our medical and interprofessional addiction medicine conferences. And we have a few talks there this year, and next year's will be in Alberta. So the other thing that's great that came after COVID was the ability to do talks over Zoom. So, you know, even for some of our research, we've been able to present to Columbia University just over Zoom, and you don't have all the travel expenses. So I think, you know, certainly when it's published, there's much more opportunity to have people ask you to present and to find places to do that. We do spend some time with our team at BC Women's, translating knowledge amongst our leadership for what we're doing in terms of the clinical models, and then building into the next kind of research grant applications so that we can continue the knowledge translation. But thanks for the question, Nicole.
That's great. And I'm just curious, perhaps it's not at this stage yet, and you definitely have a clinician audience focus, but do you think that there's any sort of findings that are, you know, ready for, like, is there any messaging to the public about these results that would be helpful in maybe stigma decreasing?
Yeah, I mean, it's a great question. I think at the heart of it is that women and birth parents are really committed to their babies. They really love them, and that it is possible to operate within this model of keeping dyads together. And it really helps to break the cycle of apprehension, trauma, and then next generation substance use disorder. So I think that that's probably one of the biggest pieces, is that the work with the families right from birth is really critical.
Absolutely. Anybody have any other questions? Go ahead and raise your hand, or you can type it in the chat and I'm happy to read it out for you. Maybe while we wait for people to percolate a bit, I just wanted to ask what your next steps are with research. Like where do you want to go from here?
Wow. That's a great question. We've got lots of things happening with FIR and different projects. There's a wonderful infant holding project that's going on, looking at how keeping infants close to and carrying them can decrease their NAS or NOWS symptoms. We also have been fortunate to lead a national project looking at women's experiences of withdrawal and how they interpret their infants' withdrawal. We're hoping to get, we had some bridge funding for that, and we're hoping to have another round of funding to support that work. We have a patient advisory committee that's involved with that, as well as elders, and helping advise us on just best practice to support families and what's important to them. One of the things that, you know, has come up is the rates of breastfeeding, and if it's important to patients in this population. We've definitely heard through like the qualitative studies that it is very important to them, as well as just being treated with compassion and the awareness that there are new and different pharmacologic ways of treating substance use in pregnancy.
That's really exciting stuff. Wow. Can't wait to hear about those findings. Anybody else have any questions? Oh, here's one. So earlier in the presentation, you mentioned chart review included people who were actively on opioid agonist treatment. Do you know if those agonist treatments impacted the infants when morphine was administered to them. And I think the rest got cut off, but Travis, feel free to speak to it if there's more to that I'm not representing.
I think I understand the question, and please correct me if I did not, or if I didn't get the whole thing. But Travis, I think you're saying that if people were breastfeeding and on opiate agonist therapy, how did that impact the amount of morphine perhaps that the baby required? This particular study didn't look at that. We were just interested in establishing the safety for the infant and the vital sign review. This study was done without any type of funding really attached to it at all, kind of off the side of our desks. There are other studies. There's a 2012 study from FIR that was published by Ron Abrahams that looked at methadone methadone dose and breastfeeding, and it demonstrated that if people were on a dose of methadone that was under 100 milligrams and able to breastfeed because they were substance free at the time of birth, then those babies had a much lower chance of requiring morphine. Certainly, we have looked at different agonist therapies on FIR, and you can definitely see that if the breastfeeding is involved, there is a shorter duration or requirement for morphine. We've, even with the high fentanyl doses that people are using now, and the high tolerance that they have, and the much higher opiate agonist therapy doses that we're using, we have still seen some patients just clinically observed that have their babies have not required morphine treatment. So certainly the breastfeeding is a protective factor that's demonstrated in the literature, but we didn't look specifically at that in this study. I think the N might have been somewhat small to do that as well.
Yeah, that's great. We have a question here about how this experience could change the life of parents. Any plans for a follow-up study a few years after the birth?
We don't have that planned right now. That length of study is challenging. We do have a multi-site project that we're setting up through the Canadian Health Research Institute that hopefully we will be able to gain some of that longer term data in terms of the experience of the parent, the baby, neurodevelopmental outcomes for the infant, and so on. So hopefully we'll have more data probably in the scope of 2 years.
That's great. Another question here for someone who worked on a study of child apprehension of kids with this particular syndrome for Alaska University. And for that study, it was the rates of apprehension.
We want to get here. So I have found a few brands.
Yeah, like if you decide, Miriam, maybe if you could mute. Thank you. Sorry, I'll start again. So they worked on a study of child apprehension of kids with this with the syndrome for Alaska University, and they found that the levels of apprehension were relatively high, especially for Indigenous communities. And just wondering if you have any data about that here in BC, or if you know of any data from BC.
Yeah, great question. I mean, certainly we know that in BC, the Indigenous population is about 4% overall, and that the children in care or apprehension rate is the percentage of children in care who are Indigenous. The last statistic I looked at was 54%. So we know that it's incredibly disproportionate. We don't have data specific to neonatal opiate withdrawal syndrome prevalence in specific populations, but we do know that our population that comes to FIR, it identifies about 58% of them identify as Indigenous. So it is definitely a sociologic a problem that has impacted the Indigenous communities through the process of colonialism, disproportionately and transgenerationally. So there's a lot of work to be done just in terms of breaking down the stigma so that people can access care earlier and receive health and medical care that is focused on their well-being rather than in a stigmatizing way.
And we have a comment here from Sarka, who says the rates of discharge to foster care dropped from about 50% to about 15% in the last 15 years in newborns with NAS. So I don't know if you wanted to comment on that.
I think we've done a lot of work clinically to collaborate with external agencies and community partners, First Nations communities, as well as our healthcare centers, our community healthcare units, and child protective services to really make the apprehension the last resort. And to have longer lengths of stay as needed to support addressing all of the social determinants, which really are the primary factor feeding into the substance use disorder.
Yeah. Yeah, and then there's just another comment that says it would be really interesting to link this data to Ministry of Health admin and social services data to kind of parse that out. But
yes, yeah. Just email me, Sabrina, and we can talk.
We can make it happen.
We're always looking at new things to support the families and the staff that are doing this work.
Absolutely. Any other last minute questions? Well, if not, I just really want to thank Charissa and Taylor for giving us this presentation, for entertaining all of our various questions. It's been wonderful. And when you do receive the results of the current projects that you have going on, we would love to showcase them at a future rounds. So just really thank you. It was really great.
Thank you. Thanks everyone for having us today. And thank you, Taylor, for all your hard work.
Absolutely.
Thank you guys.
Yeah, everybody enjoy the weekend.
Thank you.
Bye.
Thanks.